Right.
So, Eman, if you would like to present our host today, we can start.
Sure. Again, good day, everyone, and welcome to our new DCB Academy session. It is my real pleasure for me to introduce one of my mentors, Professor Hyeon Kim, Associate Professor at Asan Medical Center in Seoul, Korea, which is one of the best non-leading centers in left main PCI data around the world and the management of complex coronary cases. Today, he will be speaking about IVUS guidance for left main PCI, revisiting the 5678 rule. As we know, left main PCI remains one of the most critical procedures that we perform, where precision and optimization is essential. So we are all excited for this talk, Professor Kim. The floor is yours.
Hey,
Welcome.
thanks for inviting me, and thanks for the introduction. I am Hyeon Kim from Asan Medical Center. It is my pleasure to speak today on IVUS guidance for the left main PCI. So in our daily practice, we frequently encounter patients with left main coronary artery disease. Today, I'd like to focus on more practical question about how can we optimize the procedures when we perform PCI for the left main disease. So recently, the recommendation for imaging-guided PCI have become stronger. In 2024, European guideline for chronic coronary syndrome, the use of IVUS for left main received a Class 1A recommendation. And likewise, in 2025, American guidelines for acute coronary syndrome, intravascular imaging guidance also received a Class 1A recommendation for left main or complex lesions. So, however, the benefit does not come simply from using IVUS itself. What truly matters is achieving an optimal IVUS-guided result. And these benefits is largely driven by adequate stent expansion and, of course, avoidance of procedural complications. So our work in this field has a long history, and Asan Medical Center began studying left main intervention with IVUS more than 25 years ago. And over time, this has led to several important observations. We found that IVUS-guided stenting was associated with lower mortality compared with angiography-guided PCI. And when we look at the 10-year results of the main compare registry, the benefit of IVUS guidance appears to be sustained over time. So the next question is, what is the practical target when we use IVUS to optimize PCI? So several criteria have been proposed for stent optimization. Most are based on relative expansion, but these criteria vary depending on which area is used as a reference. So in the ADAPT-DES sub-study, only the ratio of MSA and the vessel area at the MSA site was significantly associated with 2-year clinical outcomes. But more importantly, the key message is once the MSA is sufficiently large, the relative stent expansion no longer significantly impact prognosis. So these support the concept that MSA is the practical procedure target. And earlier studies showed that when the post-stenting MSA is above 5 to 5.5, the rate of angiographic restenosis becomes low. And more recently, in a pooled analysis of individual patient data from 3 large randomized trials, relative expansion were not clearly associated with outcomes, whereas an absolute value An absolute MSA threshold of 5.5 emerged as the only strong predictor of target vessel failure. And of course, although there has been no prospective randomized trial dedicated exclusively to left main, but the recently published Renovate Complex trial, which compared imaging-guided PCI versus angiographic guidance, included a left main sub-study. So in that study, imaging-guided PCI showed better clinical outcomes compared with angiographic guidance. And of course, about 60% of patients in the imaging-guided group achieved optimization according to 5678. So as in non-left main PCI, MSA is important in each individual left main segment. And one of the best known criteria for stent expansion is the 5678, which was originally proposed by Asan Medical Center. And however, these criteria were criticized as being too small, with some suggesting that they reflected the smaller vessel size typically seen in Asian patients. So the original 5678 values were derived from a mixed population, including both single stent and two stent cases. However, it remains unclear whether the original criteria were smaller simply because they were derived from an Asian population. And in fact, earlier studies of normal coronary arteries suggested that Asians may have smaller lumen dimension. However, when we look at the left main by IVUS, the overall vessel size appears quite similar between Asian and Western patients. Also, the minimal lumen area threshold predicting functional significance of left main may differ between population, but the actual left main vessel area measured by IVUS was remarkably similar. And the actual distribution of left main from the original study was not particularly small compared with other major studies. And in fact, the Excel criteria and the Spanish registry showed a very similar range of MSA distribution. So maybe we are not as different as we once thought. And the Excel trial, however, identified a larger MSA threshold than 5678. And specifically, they suggested 7.3 for the LAD and 5.7 for the circumflex. They predicted 3-year death, MI, stroke. Similarly, a post-hoc analysis of the novel study showed that patients with a left main less than 11 experienced significantly worse clinical outcomes. So one likely lesion that the original threshold appears small is that they were designed to predict angiographic restenosis rather than hard clinical outcomes. So this brings us to our more recent work. And in our new study, we included patients with a planned two-stent crush technique, and we only enrolled cases with finer IVUS pullback from both from LAD and the circumflex. Our goal was to define segmental MSA to predict 5-year major adverse cardiovascular events. So when we examine the MSA distribution, the median MSA for the distal left main was 10.8, which was very consistent with prior international studies. We then use these IVUS-derived measurements to generate ROC curves. Both the LAD ostium and the circumflex ostium show the AUC greater than 0.6. And using these best cutoff values, the Kaplan-Meier curves demonstrate a clear separation in MACE rates except for the distal left main. So the distal left main itself was not directly associated with adverse events. Instead, underexpansion at the two outlets of the bifurcation was much more important. So ensuring optimal stent expansion at both the LAD and the circumflex is really the key determinant of the long-term success. And so this might get confusing, but this means that even if the distal left main remains below 11, long-term clinical outcomes are still good as long as both branch outlets are well expanded. And by maximizing the two outlets, the distal left main area inevitably increases, so, which is why the distal left main itself seems to carry less meaning in this specific context. And then comes the next question. What about the one-stent strategy? What is the optimal MSA in left main one-stent crossover? To answer this, we analyzed a new cohort patients who treated with crossover stenting. This was a completely separate and contemporary data set, and we excluded patients who required a bailout second stent in the circumflex. So in this cohort, the proximal left main MSA emerged as a strongest predictor. Patients with a proximal left main less than 11.4 had significantly worse clinical outcomes. In contrast, the distal left main and the LAD ostium each had limited ability to predict future events on their own. So we believe this is because the circumflex ostium remains the weak point of the one-stent strategy. In fact, many left main related repeat revascularization after crossover stenting are driven by the circumflex ostium, which limits the predictive value of the distal left main or LAD MSA alone. And again, I want to highlight the striking similarity between in MSA distribution across all of our pivotal studies and the, of course, Excel criteria, which strongly support the robustness and the consistency of our data. So taking both our data together, the practical targets can be summarized in new way as a 6, 8, 11 criteria. So for one-stent crossover PCI, prognosis is mainly driven by securing a large proximal left main with a target approximately 11. And for a two-stent PCI, long-term success is depend on avoiding underexpansion at both branch ostium, targeting approximately 8 for the LAD and 6 for the circumflex ostium. And of course, there are several important questions remains unresolved. And the first is whether small finer MSA always means stent underexpansion, or whether in some cases it simply reflects a small reference vessel. In other words, was the stent capable of further expansion but not fully expanded, or was it already fully expanded within a small vessel? And this distinction is important, and we are continuing to investigate it. And the second issue is whether intracoronary imaging can help identify the left main lesions that may benefit from an upfront two-stent strategy. So this question is important because the circumflex is not just another JLD side branch. Unlike the non-left main bifurcation, the circumflex is usually large enough to treat and often supplies a substantial myocardial mass. So the preserving the circumflex is critical. In our ongoing analysis using a pre-stenting IVUS from the circumflex, we found that a small minimal lumen area and a high plaque burden at the ostium can predict acute cell complex compromise after crossover stenting. We are preparing now a third paper about this. So to summarize, first, intravascular imaging is essential during left main PCI, and the MSA remains the key predictor of long-term success, but the relevant target depends on the stenting strategy. So in two-stent PCI, we should focus on both branch outlets, whereas in one-stent PCI, securing a large proximal left main is important. So to conclude, segmental MSA remains central, and with more practical shift towards to 6, 8, 11 criteria. So thank you for your attention.
Thank you, Dr. Kim. This was a really inspiring presentation, very focused on a topic that is so important. And I fully agree with, I learned a lot, and I fully agree with your conclusions. And I have to say that we should clearly say that if you don't use intravascular imaging, if you don't have it, if it's too expensive, because I still listen to colleagues that say, we are not using imaging, it's too expensive, it's not reimbursed. Okay, it's fine. Don't use imaging, so don't do left main PCI. Please. If you don't use imaging, you should not use left main PCI, because it's not scientific. So this is also an ethical problem, because we have a huge amount of data from you and also from other centers that are showing that you must use imaging for left main PCI. Again, if you don't have imaging, guys, don't do left main PCI, like you shouldn't do ISR. Same problem. There are still centers that don't do imaging for ISR. You should, with Wojciech, we also published a lot about that. For ISR, you should use imaging. And I would also like to share this very recent data that we generated. So this is the ROC3 study. Okay, so we did this also with Wojciech. It's the third study of left main imaging for left main. We already published ROC1 and ROC2. So ROC3 is very interesting because it's comparing the performance of intravascular imaging for left main to CABG. Okay, so we have a cohort of intravascular imaging guided PCI, either OCT or IVUS versus CABG with a 2-year follow-up. And it's very interesting to see that in terms of MACE, there is no difference. There is still an increase in the myocardial infarction in the stent group, and there is still an increase in stroke in the CABG group. And this is real-world data, and it's very important. So this is not published yet. It's under the second revision at CCI. So that said, I would also like to overemphasize another point, as you correctly said. Okay, if you have the expertise and if the lesion deserves to stent, you should go for two stenting for left main. If you don't have the expertise, you should use, let's say, simpler techniques, including also drug-coated balloons. Of course, we are biased. We use a lot of drug-coated balloons, but using a DCB for the ostium of the circumflex has shown in as many small studies that the angiographic and also the clinical performance in a meta-analysis is better. Of course, we are still lacking the amount of data that you have already provided with the two-stent strategies, but I think that this is the way to go in the next few years to spare the total amount of stenting, because especially, I would say, in not very experienced centers, the performance of DK crash or also culotte or also TAP techniques are not as good as those that are performed in your center.
Thank you for your
any comment
opinion.
from the team here?
Dr. Kim, thank you for a very nice talk. Bard Kilani from Singapore. I just had a question about the use of IVUS for pre-PCI. So we have a lot of, in Singapore, we have Asian patients, they're quite small built, and we're using the sort of Professor Park's criteria for determining if the left main is significant or not. So, 4.8. If it's above that, in that 4.8 to 6, I tend to do the pressure wire just to reassure myself that I'm doing the right thing. But I don't know if you can just comment on that with regards to that gray zone, that sort of 4.8 to 6 millimeters square. And sort of either sending these patients for surgery or doing PCI. What your thoughts about that?
Yes, that is actually very good question, because the minimal lumen threshold to predict the functional significance of left main, it seems that there is ethnic difference. Like for Asians, S.J. Park used 4.5 or 4.8, but we usually depends on the FFR. So our treatment decision is mainly dependent on FFR, not the IVUS. So whether to revascularize it or not for the left main, we are pretty much dependent on FFR guided decision making. So and about other things, like as the Professor Cortez mentioned, that for example, if we decided to doing a left main PCI, whether it is a 1 stent or 2 stent, we evaluate the circumflex ostium for IVUS, and we are actually depending on our this data. So if the minimal lumen area of the circumflex is less than 3.8, or the plaque burden is more than 57 or 60%, then we consider 2-stent strategy to prevent the circumflex jailing. Or now in these days, I prefer the DCB at the circumflex ostium, and then to make a procedure more simple. So like for crossover stenting.
Thank you very much.
Can you hear me? I'm sorry, I'm on the flight, so I don't know whether you can hear me at all.
We
Hi,
can hear
Sandeep.
you.
Yes, sure. Welcome.
Oh, okay. Sorry, I've got joined late because of the network issues, but thank you so much for the presentation. I want to ask the question about the DCB in the sarcostium. I know Bernardo does a lot, we do a lot, and it's kind of changing the practice. But whenever I suggest DCB in the sarcostium, we have to probably use a very aggressive ballooning, like maybe cutting balloon or sometimes even more. And that results in a dissection. And how do we kind of convince the operators to kind of accept it? Because if you don't use a specialized balloon, you will not probably get a angiographically less recoil. And moment you get a dissection, people are concerned about putting a stent. Obviously, if you stent the side branch first, you have to go with a DK crush. But if you don't stent the side branch first, you have to do it later. Then you have to go for a tap or a reverse pull out or a crush. So how do we balance this? Because it's every time I speak to my colleagues, it's they're worried about the dissection and having a balance between a good lesion preparation and a dissection.
Yeah, my point, Sandeep, is it's the problem of the circumflex is really anatomical, and as the vessel and histological as the vessel is made. The problem is also to achieve a good stent area with a stent, a good final area with a stent. It's very difficult. because this area is very prone to recoil, and in some patients, there is a specific amount of calcium, which is difficult to deal with. So we have recoil with stents and also with DCB. And I agree with you, we need to use specialty balloons in this area. We need to use cutting balloons. Probably cutting is better, but this is just my personal opinion. I don't have data to suffragate this point, but cutting balloon is probably better than if you are able to navigate and to do the bending, than scoring balloon there. In terms of dissection, I think I would suggest to apply the same rules that we are applying for the other dissections. So if you have a final good area, either also with imaging, but also with angiography, or if you have if you have a good flow, if you don't have recoil, that's the way to go. Dissections are good for DCBs in the end.
Yes, I agree with the professor. So during or preparing like MSA criteria, it seems that if we are not gonna able to secure like enough MSA for the circumflex ostium, then it is better not to stent it. So that's in that point, I prefer DCB for the circumflex ostium. So as you already mentioned, it usually have a very calcified nodules or something like that. So even if we do the thorough rhythm preparation using NC balloon or a cutting balloon, the circumflex ostium is hard to get enough space. So if you anticipate that circumflex ostial MSA will be like less than 6, then it might be better not to stent it.
Yeah. All right. Any other burning question? This is a unique opportunity to have Professor Kim with all of the expertise, which is bringing a huge expertise in the last, how many years? 22 years, 24 years? When did you start doing this
25.
job in treating the left main? So it's a really unique opportunity for us to learn something. Emma, how long are you staying there in Seoul?
That's a sad question because I only have 5 months left for me. Out of 2 years, yeah.
Try to bring everything from there,
I'm
all
trying
of the
my best.
expertise, and
He's
it would be
actually
very nice also to activate some scientific collaboration with
definitely.
our foundation and Professor Park and Kim's team to do some science together.
Yeah.
I would be
Professor,
very
can I
honored.
ask one more question? Sorry to interrupt.
Please, sure, Vakas.
Yeah, thank you. Now, one thing I just want to clear that in sometimes we are not able to get the absolute expansion index. So for that arteries, can we go for relative expansion index to conclude in the end? Like sometimes we are using absolute criteria, but absolute criteria is not fulfilling. So what we can do, we will go with more expansion, or just we will consider the relative expansion index and just conclude the final result.
Yes. At that moment, you have to decide whether the vessel is truly small, so you cannot expand more. So
Yeah.
but I still think that securing the absolute MSA is the first step. If you cannot achieve enough MSA, then you should look for the relative expansion criteria. But it is the Spanish registry, they suggest the relative expansion criteria for the left main PCI, or you can use this this graph shows that we can use some of the fractal ratio, like from the LAD and the circumflex, and so if the vessel is small but they are fully expanded, but not achieved absolute size, they still have some good outcome. So I think the number one step is the securing MSA. It usually achieve like a left main or LAD is okay, but circumflex is always the problem. So you should look for the vessel size, whether the circumflex vessel is large enough than 2.75 or something. So, and then you try to maximize the MSA as large as you can get.
Yeah, thank you. Thank you.
Dear Professor Kim, here is Wojtek from Poland, from Katowice Medical University Center. I have a question because we have a lot of stents on the market, from thin, ultra thin stents. And could you tell us and maybe compare the outcomes of the treatment of left main depends of the thin strats, thin of the thin or very
Good question.
thin strats in the left main, and is the place also for the dedicated left main stand in the future? Also, far we had some dedicated stands, but now nobody is talking about dedicated stands for the left main. So, do you think that in the future we will see dedicated stand for the left main, for the bifurcation left main, so such on?
Yeah. For the first question, I don't really have a special experience with ultra thin strut, and to be honest, me and most of my colleagues doesn't feel the difference between the whichever stent we use. So we usually prefer like Giants or every other stand as without a preference. So, and also about the dedicated stand for the left main, I think I think it might not need. Yeah, is as long as we can do left main PCI with imaging guidance and the thorough region preparation, and then achieving the MSA, achieving the MSA like 5.7 is not that difficult for most patients, because the vessel is usually enough size, like even for Asian patients.
Yeah. All right. So if there are no other questions, I think we can close. It was a very fruitful and interesting lesson on when, which is always 100%, and how to interpret data that are deriving from IVUS for the left main. We didn't discuss about OCT, but maybe we can dedicate another lesson to the usage of those OCT for distal left main. So far, I have to admit that IVUS have more data, and so that should be the first choice of imaging. But if you don't use imaging, you don't have to do left main PCI. And if you prefer to use OCT, it's better than using nothing. So this is my personal opinion. So thanks a lot, Professor Kim, on behalf of DCB Academy. And again, thank you, Eman, for this great connection.
Thank you for being
Have
here,
a good day.
all of you. Have a good night and
Bye-bye.
good day. Bye-bye.
Thank
Yeah,
you.
bye-bye.
Thank you so much.